Good afternoon. It is my honor and a pleasure today to be the moderator of this very prestigious session. Very prestigious because we have a very prestigious and a well-known figure and a legend in nephrology in Egypt and all over the Arab world and even all over the world, Professor Muhammad Hani Hafiz, Professor of Nephrology, Cairo University. He is a well-known figure. He is the current president of Egyptian Society of Nephrology and Transplantation, and I think Secretary General of the African Society, Dr. Hani, nowadays.
Associate Secretary. Associate
Secretary of the African Society of Nephrology. All of us learned a lot from Professor Hani Hafiz, and his presence with us today is a real privilege. Today, he is going to discuss, this is the second session of acute kidney injury, and the title is very interesting, Detection and the Management of Acute Kidney Injury in the Developing World. Professor Hani.
Thank you very much, Professor Hussein, for this very kind introduction. And I will try to, in my presentation, to divide it into three parts. In the first part, I will detail the epidemiology and the classification of acute kidney injury. And in the second part, which is meant to be the longest part, what is the etiology in the developing world? And last part will be the treatment, if there is any peculiarity for the developing world, or it is just go like the rest of the world. Let's go and see that in the ISN Atlas that has been published twice, the first time in 2017, and then the recent publication was in 2019. And see the acute kidney injury world burden. And we'll be astonished that less than half, only 41% of the countries were able to estimate the prevalence of acute kidney injury requiring dialysis. And for those not requiring dialysis, only 19% gave data. So it is very pure epidemiological background about the acute kidney injury worldwide. Although that we know that in critically ill patients, up to 40% at ICU admission have acute kidney injury, and 60% of the patient during hospitalization. So we are dealing with a very, very important subject. And we know that AKI and chronic kidney disease are closely related. One of them is CKD is a known risk factor and for AKI and vice versa. And in the developing countries, we will have many causes that I will detail further. Let's go and see. Let's go a little bit and see what is the prevalence of treatment of end-stage renal disease in the developing world. If you look to Africa, you will see that many places are very deficient in treatment of dialysis. Also in many parts of Asia, and also in some areas of the South America. So it seems that the developing world is not is ready for treating end-stage renal disease per million population. And when we see the burden of the hypertension in the same places, we see that it is dark blue. So it is, we have a very big burden of hypertension and also a very big burden of diabetes, as I will show you in a minute. And in spite of this, we don't have the facility to treat patients for when they develop end-stage renal disease. Actually, also in sub-Saharan Africa, glomerulonephritis is an important cause. And so early recognition of acute kidney injury and appropriate intervention will decrease the suffering, because many of these people, if they go to end-stage renal disease, renal failure means death. When we see the diabetes, it is not different. This is the recent IDF calculations for Africa. It is expected that on 2045, there will be 143% increase in Africa and 96% increase in the Middle East and North Africa, as compared to 33% in the United States and 15% in Europe. So our area, and also the Southeast Asia, have higher burden of diabetes in the next period. Also, when we look to the acute kidney injury era ELITA data, we see that it is, and ASN data, we see that they say that they have 13.3 million case, which is actually around more than 3 times the individual on renal replacement therapy in the world. So we are dealing with a very, very important problem. And when we go and see different studies on the midline, the pooled incidence of acute kidney injury was varying between 21% in adults and 33% in children in different areas of the world. But the mortality was inversely related to the income of the countries and the percentage of gross domestic product spent on total health expenditure. These are the classification, the old classification, AKI, stage 1, 2, 3, rifle, risk, injury, failure, loss, and stage 3 kidney disease. But they found that rifle and Akin don't match in the same case. So you may have a patient classified by one stage as risk, although it is by another, it is stage 1. So it was not matching very much. And therefore, in 2012, there was this KDIGO criteria, which are much more simpler, stage 1, 2, 3 only. If the creatinine is 0.3 increase in serum creatinine in less than 48 hours, or increase by more than 1.5 the baseline, stage 1, more than 2, stage 2, more than 3 times, stage 3. And the urine output also is very simple to see, less than 0.5 milli per kg per hour in 6 to 12 hours, or more than 12 hours, or more than 24 hours. So this simple classification is adopted, and I want you to remember with me the 0.3 milli per kg per hour, because we will come to it later on after a minute. Why we are giving this talk? What is the main concern? Not only because of the statistics, poor statistics that I mentioned, but because the AKI survivors, 49% are rehospitalized at least once, and around quarter of them die, and around quarter of them have at least another episode of AKI. So it is a very serious disease, not amenable to control yet. Why? Maybe because of its multi-organ failure affection involving many cytokines. You see here that tumor necrosis 1, for example, and affecting the heart and the lungs. Any decrease antioxidant and increased leukocyte influx in the liver, in the brain, and affecting the microglia and the vascular permeability. And this was actually the underlying idea of using high permeability hemofiltration to get rid of these cytokines in some cases of septic acute kidney injury. And mind you that if you have acute kidney injury, you have twice the risk to develop respiratory failure, requiring mechanical ventilation, and you have 80% possibility of mortality versus 30% possibility of mortality if the patient is not ventilated. Again, the liver is not away from this injury, and I think by this septic acute kidney injury also, you are affecting all the organs, brain, heart, lung, liver, intestine, and immune system with a very high mortality. So, if it is so bad, do we want to have some biomarkers to detect it a little bit early? But in the developing countries, we don't have money to get biomarker. But we have this concept of 0.3 that I told you to try to remember. Urine output 0.3 milligram per kg per hour. So if you have less than 0.3 milligram per kg per hour, this was associated with acute kidney injury, bad prognosis, more than doubling the risk. So it is very important, simple parameter, intraoperative estimation of the urine output. And if it is more, if it is less than 0.3, this will be risky. If it is more than 0.3 or more than 0.5, not associated or less associated with acute kidney injury. Again, we have another value for this 0.3 in more developed countries, but I will give you the hint. In this astute SAPHIR study, they tried to compare different biomarkers, the plasma and the urine KIM1, and they found that the most accurate, actually, was this TIMP2 IGFB7. Actually, these are both markers of the GROS1 phase of the cell injury. So when the cells are injured, they release this as a spreading alarm telling us that acute kidney injury is coming. And therefore, let's remember again this number 0.3. If you have a TIMP2 IGFB7 more than 0.3, this is a bad alarm that we will have injury coming. So increase the volume substitution, consult a nephrologist, and try to work rapidly. So we have a preliminary 0.3, which is the urine, and one more advanced 0.3, which is this TIMP2 IGFB7. About how to diagnose early and how to be upset by the bad prognosis of these patients. And therefore, we will try to dig now about the etiology in our developing world. Do you think that acute kidney injury will be different from what we see in the textbooks? Pre-renal, intrinsic, or post-renal? Basically, it is not. It is almost the same mechanisms: acute GN, acute tubulointerstitial nephritis, tubular necrosis, ischemic or nephrotoxic, post-renal. Basically, it is the same skeleton. But we will focus on some important points. Let's start by seeing which prognosis is better than the other. If you have an induced AKI, for example, by diuresis or by RAS inhibition or by SGL2 inhibitors, usually the outcome is better. But if you have a spontaneous AKI, like what we see in the cardiorenal syndromes, the hepatorenal syndrome, the sepsis, or the nephrotoxins, usually the outcome will be worse. Let's see the cardiorenal syndrome, which is, we see that the cardiac affection in our developing world is increasing. And actually, we have acute worsening of the cardiac function leading to acute kidney injury. And this affection has got, as I told you, some biomarkers to detect it. And it will affect definitely the life of the patient unless you treat by different manners, including the diuretics, the inotropes, and possibly the ultrafiltration in late cases. And AKI itself could be associated with de novo heart failure, as you see that in this study in 2018 in the American Journal of Kidney Disease. This could happen in absence of previous heart failure whenever you have acute kidney injury. Let's go now to the second most important etiology in Africa, the infections, and in the developing world in general. Nowadays, infection is everywhere with the COVID-19, but there are specific causes which are endemic in some parts of the world: malaria, TB, hepatitis, HIV in some places with its different pathological affection of the glomeruli, the tubulointerstitium, the vascular, or the hemorrhagic fever that affected at a time West Africa in 2014 and 2015, causing an epidemic of Ebola at that time, which was a viral hemorrhagic fever with vomiting and diarrhea, and also leading to acute kidney injury. The problem in our developing countries is the defective control policies and procedures. Sometimes denial of some infectious disease as HIV, sometimes holistic management of malaria or hepatitis C, for example, except in few countries, and non-accurate statistics for policymakers. And when we see, for example, how hepatitis C was affecting and causing acute kidney injury, we see it in several ways. The most common is the cryoglobulinemic vasculitis, which has been reported in around 1 to 5% of the patients, and with multiple risk factors. And AKI is clinically associated with oliguria, hematuria, and several extrarenal manifestations of cryomyalgia, arthralgia, and characteristic skin rash of Meltzer triad. And actually, the treatment of this catastrophic cryoglobulinemic vasculitis was poor, with a cure rate of only 30% and partial response in about 50%, including sometimes the measures that we cannot afford in the developing countries. But we give, of course, the antiviral treatment, the pulse steroids, rituximab, and such expensive medication could be available, and plasmapheresis in some cases. Let's go to another important issue in the developing countries, which is the rhabdomyolysis. 10 to 40% of patients of rhabdomyolysis develop acute kidney injury, and up to 15% of all causes of cases of AKI can be attributed to it. These percentages increases in children. Why in developing countries we have more rhabdomyolysis? High body temperature, heavy manual work, strenuous exercises, crush syndromes, all types of infections that I mentioned, abuse of substances, opium, amphetamine, alcohol, etc. And this will result in destruction. You see here, the ATP reduction and the sodium potassium ATPase destruction will lead to more influx of calcium inside the muscle cell, and we get different complications. We get hypovolemia, we get compartmental syndrome, we get hyperkalemia, hyperphosphatemia, hypercalcemia, and up to disseminated intravascular coagulation. And another important aspect, actually, in our countries, when we speak about the liver affection by hepatitis C, hepatitis B in the developing world, we should speak about liver failure, and which will progress to cirrhosis and liver failure. And there is an important discrimination between the poor prognosis of hepatorenal syndrome and the less poor prognosis of parenchymal nephropathy or hypovolemia in a liver patient. So it is crucial to differentiate, because we know that if we have hepatorenal syndrome, the prognosis will be bad. And this criterion, very simple equation by the American Society of Liver Disease, using the differential diagnosis of acute kidney injury in cirrhosis by just measuring the fractional excretion of urea. If you have a fractional excretion of urea of less than 28, this is more for hepatorenal syndrome in comparison to other causes of kidney affection in liver patient. And as you know, we have type 1 and type 2 with different prognosis, and we have different lines of treatment, which is not the case now to detail them, including the torlipressin, including the midodrine, the dopamine plus furosemide plus octreotide, and the albumin. All these has been tried with different results in different studies. Now let's go to another important etiology in developing world, which is the acute kidney injury in pregnancy. And in comparison to the developed nation, we have peculiar causes in the developing world. Poor socioeconomic status, malnutrition and obesity, lack of access to care, infection control practices inadequate, and surgical resources much less. And when we see the countries' reports on the preeclampsia and eclampsia in 2010 to 2010 by the WHO, you see that, of course, some areas do not report. But you see that even in the reporting countries reporting both preeclampsia and eclampsia, you will find many places from the developing world. You see here many places in Africa, in Asia, and in South America. And this is pregnancy-related AKI, preeclampsia and eclampsia, cause over 50,000 maternal deaths worldwide per year, according to these statistics in 2012. Is preeclampsia and eclampsia the only problem in the pregnancy in the developing world? Of course, no. Let's study the Prakash from India. He made a study, started his study in between causing the AKI incidence in the between 82 and 1991, and the incidence was 15%. In the following decade, it decreased to 10%. And later on, from 2014 to 2016, it decreased to 2.7%. So India is showing much improvement in the risk, maybe because of the improvement of the criteria that I mentioned to you. And of course, this AKI incidence in India is not different from Pakistan. For example, the study published in 2019 from Pakistan shows that the AKI here is mainly because of postpartum hemorrhage in around 37% of cases, prepartum in around 19%, and puerperal sepsis in around 29%. So we still have a big problem in this part of the continent. And the timing of AKI in pregnancy is crucial in knowing the etiology. So in the first trimester, we have the septic abortion and hyperemesis gravidarum with the acute pyelonephritis going from second trimester, TTP, and the third trimester is associated, as you know, with the preeclampsia, eclampsia, acute fatty liver, cortical necrosis, and obstruction, etc. And this is, of course, this table to differentiate between these causes. All of you are familiar to it in textbooks, but it is important to stress that in our developing countries, still the pregnancy is an important cause. And the outcome of AKI in pregnancy, retrospective study also, again, this is coming from India, 2006 to 2011, needing at least one session of dialysis. 98 cases out of 2,890 needed dialysis, and the most common reason was post-abortal sepsis. And the maternal outcome, 65% achieved complete recovery, this is good, but 18.3% of the women died, which is again another catastrophe. Let's go now and go away from the science and think of the environment. And this American biologist, Raquel Carson, wrote a book which is called Silent Spring in 1962. And that book changed the world because it was mentioning the danger of chemical pesticides on humans and nature. This lady earned a master's degree in marine biology from Johns Hopkins University, and she got many awards, and she thought that it is natural to combine literature and science because the goal of both is to shed light on the truth. Of course, she has been, after that book, she has been attacked by policymakers. In 1960, approximately 638 million pounds of pesticides were put into the environment. And this business amounted to $250 million at that time. But with her perseverance, she succeeded to give this warning to the world. And by her warning, there was virtual ban on the powerful pesticide DDT at that time in the 60s. But half a century ago, more than half a century later, in 2016, we have again this environmental concern, but now it is coming from the sea Jason. And we see here in this 1,607 article, 69% conducted in different endemic countries, Sri Lanka, Nicaragua, El Salvador, some Arabic countries like Tunisia, African like Tanzania, and many places. They found that heavy metals, heat stress, dietary exposure, and agrochemical use, all of these are important causes of what we nephrologists were mentioning as renal disease of unknown etiology. So it is known that we have an environmental pollution, exactly like this lady mentioned more than half ago, Rachel Carson, but now let's go and face the problem that we have. What about heavy metal nephropathy? We can diagnose it by the triad of kidney disease of unknown etiology, Fanconi syndrome and tubular damage, multi-system involvement, including the kidney, of course, and occupational and environmental exposure. The most common are the cadmium, which is present in everywhere around us, actually. In cigarettes, sewage, burned garbage, cadmium exposed industry, in manufacture of alloys, batteries, and you see here the history of exposure: kidney stone, gout, proximal tubular dysphosphomalacia, and you diagnose by increase of the blood cadmium level, and beta-2 microglobulin will be very elevated. Also, lead was very common in the past and still common in our developing world. It's triad of renal failure, hypertension, and gout present in pipes, lead solder, lead paints, lead gasoline, exposure more than 5 years, and probably it is common in more place in developing countries. And you diagnose by a blood level more than 60 microgram per deciliter. Again, we have chromium, which is a remedy for weight loss, lipid lowering, and glucose control. But if you take it in big doses, you may have toxicity. Arsenic, which is present in some herbal medicine. And this is an important subject that has been in many new articles in 2019 and in 2020. What about mycotoxins? Mycotoxins are, when you see this map of the world, you see that high risk is present in most developing world, and low risk is only in the modern areas of United States and Europe. And of course, this high risk of mycotoxin has been one of the causes of Balkan endemic nephropathy in the Balkan area. And many of these mycotoxins are bad. Aflatoxin, of course, you know it is very bad for the liver. Fumonisin, but for the kidney, ochratoxin specifically is very important. All of these are present in the corn, in our food, in our daily food. And therefore, two very eminent papers came from the Mansoura group, Professor Sobh, and also my co-chair, Professor Hussein Shuaisha, one about the human ochratoxin and nephropathy in Egypt has been published in 1998, and another one later on, a study of ochratoxin as an environmental risk that causes renal injury in breastfed infants, Egyptian infants. So ochratoxin, of course, is an important, not only the ochratoxin, but all the mycotoxins in the different grains are very important. Now, let's go and see another worry, which is presented in the American Society of Nephrology in November 2019 by Professor Marc Dubrow from Belgium, who came to Egypt, and in our Egyptian Congress, he again stressed this danger of chronic interstitial nephritis in agricultural community, or let's say it, CNAC. As you see, this CNAC will decrease the GFR from its classic rate of decrease by 1 milli per minute per year to 5 milli per minute per year. So it will lead to progressive renal damage. And it is increasing global wide. But there are some areas in the world, as you see in this map, which are more prone, including the Mesoamerican nephropathy. And we see areas here like El Salvador, Nicaragua, Brazil, and Peru. And also it could be an explanation for CKD of unknown etiology, as the metal, that story that I gave you an idea about. Multivariate analysis show that this CNAC was among participants who drank well water, a higher risk, more than 2.5% the risk, and had a history of drinking water from an abandoned well, and also if they are living in an area in which pesticides are used, especially these pesticides used in Sri Lanka and El Salvador, including glyphosate, paraquat, and other organophosphate. These several pesticides will lead to a picture looking like the calcineurin inhibitor toxicity that we see in our transplant patients who are getting big doses of drugs, and we can detect it by minimal diagnostic criteria, decrease in the GFR, absence of proteinuria of tubular type, and living and working place in this agricultural community, and absence of other causes of CKD like the diabetes, hypertension, etc. It is more common in men and living in a hot climate, and these are good for this diagnosis. And if you take a biopsy for this, you will find, as I mentioned to you, a picture which is very similar to the calcineurin toxicity: vascular hydinosis, tubular atrophy, cellular infiltration, stripped fibrosis, which is very important for the calcineurin, isometric vacuolization, and accumulation of enlarged dysmorphic lysosomes, typical by electron microscopy. Now let's go to the traditional complementary and alternative medicine in Africa. Actually, it is not in Africa. It is in Africa, in Asia, in China, everywhere in the world. They found by the WHO that 80% of the world population relies upon this we call it TCAM therapy, traditional complementary and alternative medicine, for their primary health care. I mean, they will take this before going to any doctor. Unfortunately, this will lead to nephrotoxicity. And this was a study coming from South Africa, from Durban, on 226 patients with AKI, followed for 3 years. And they found that the nephrotoxin accounted for 20% of the cases, and the infection 30% of the cases. So it seems that after the infection, these nephrotoxin from the TCAM or the complementary and alternative medicine is a very important cause in our developing world. And let's give some examples. Now we are in Ramadan. We take licorice, and as little as 200 milligrams daily for 2 weeks, which is 1 cup only, is enough to raise your blood pressure. I'm not frightening you, but these are the facts. And so hypertension, sodium retention, hyperkalemia, hypokalemia may come and induce different affection, including rhabdomyolysis. The Salix daphnoides, active constituent of the salicine, used as an analgesic anti-inflammatory agent, is associated with AKI and papillary necrosis. This Chinese herb, in 2008, they reported in the literature many cases that increased by 2018. And these are 7 nephrology centers in Brussels found that women trying to lose their weight by this herbal medicine used for slimming are increasing in number. And these actually, the material was belladonna extract, Stephania tetrandra, and Magnolia officinalis. These were, and this is Stephania tetrandra picture, and these lead to rapidly progressive interstitial renal fibrosis in young women associated with slimming regimen, including Chinese herbs. What is the mechanism of this affection? The different mechanism. You see that high drug delivery by the renal blood flow to the kidney, cellular uptake of the toxin, increase local drug concentration if you give big doses, and again, high metabolic rates and biotransformation of some drugs to other more toxic material, leading to more affection of the kidney. What about an item that we call crystalline nephropathy. We know that crystalline nephropathy is not only caused by drugs or by substances, but we can classify it into 3 types. Vascular, which is the atherosclerotic renal disease, type 1. Type 2, intratubular, which is acute phosphate nephropathy that I will mention in 1 minute. And drug-induced, this is the most important for us. And type 3, urolithiasis, which is causing stones, which are also an important cause of post-obstructive acute kidney injury in our developing world. What about the drug-induced? Enteric crystal nephropathy, tumor lysis syndrome, and I will come to it when I'm discussing the malignancy after a while. Rhabdomyolysis, I just mentioned it. Bile cast nephropathy and light chain cast nephropathy, again in malignancy. What about acute phosphate nephropathy and why it is important in developing countries? Because this fleet phosphosoda was condemned in different parts of the world, this purgative. It was not anymore the oral sodium phosphate and the sodium phosphate containing anymore. But still, they are used in some parts. And this is a study on 11 elderly patients received the feet enema for constipation. Acute renal failure was present in all patients. 2 patients required urgent hemodialysis with poor outcome in this publication in 2012. And the FDA issued a warning that using more than 1 dose in 24 hours is serious. And I don't think that we are following this FDA very accurately. So acute phosphate nephropathy is also in danger. What about the drug-related crystal-induced acute kidney injury? Protease inhibitor for HIV treatment, acyclovir, sulfonamide, ciprofloxacin, very commonly used, orlistat, another drug used for slimming beside the herbal medicine. All of these may lead to drug-related crystal-induced acute kidney injury, and high-dose vitamin C that sometimes we take without any reason is not very good. What about other drug toxicities increasing the dilemma? Of course, in our developing countries, we prescribe the antibiotics without any prescription by a doctor. In many places, we can get it from the pharmacy directly. And in this dilemma of multi-drug resistance, we are sometimes forced to use second or third generation of antibiotics like the colistin with its associated acute kidney injury, which should be diagnosed by getting, if the hemoglobin is low in the first 72 hours. What about the tumor lysis syndrome that I was mentioning, another cause of crystal-induced nephropathy? And this will open to us the spectrum of onconephrology. Of course, onconephrology in Africa, I will not be very advanced like in or in the Asia and developing countries, but we share the burden of having this chemotherapy leading to acute kidney injury by different mechanisms. And you see the tumor lysis syndrome as an example. And the conventional chemotherapeutic agents like cisplatin causing TMA, pamidronate causing collapsing FSGS, zoledronate causing toxic ATI and ATM, methotrexate causing crystalline acute tubulointerstitial nephropathy. And of course, some of our places are using the new medications or what we call the biologicals. And when these biologicals came, we thought that they are away from nephrotoxicity. But unfortunately, the immune checkpoint inhibitors, the CTLA4 and the anti-PD-1 and the PD-L1 antibodies, again, they proved to be nephrotoxic and they cause kidney injury in 2.2% of cases, with a percentage reaching up to 5% in some reports. And another group coming nowadays, which is the chimeric antigen receptor, T-cell toxicity in this Iliana trial, again causing acute kidney injury in 24% of the cases. So we have a big problem with these new drugs that we are using. What about the contrast? Professor Hussein last time mentioned in detail the contrast-induced nephropathy, but I will just mentioned that, of course, in our developing countries, we are performing much investigations, including CT scans, including all the investigation leading contrast. And there are nowadays some people who are saying that contrast-induced nephropathy is not a big concern, in spite of others saying that no, it is important, especially if the GFR is between 30 and 45 milliliter per minute. We should take care of it. And we have different protocols to assess the amount of dye to be given and the type of dye, including this Mehran criteria. Now let's go to the last part of my presentation after I detailed to you what's happening in the etiology in the developing world and which is the treatment. Is there any peculiarity in the treatment? Of course, when we see this catastrophe of high mortality, we should go first to primary prevention. Primary prevention is the key. Start when patients are at high risk in the first stages of AKI according to the KDIGO. Discontinue all nephrotoxic agents when possible. Ensure volume status and perfusion pressure. Consider functional hemodynamic monitoring. Monitor serum creatinine, urine output, avoid hyperglycemia, consider alternative to radiocontrast procedure. And then start to use the simple biomarkers and check for changes in the drug dosing, consider renal replacement therapy and the ICU admission if the condition deteriorates because of this multi-organ affection. And this is important preventive guidelines. It's very important to differentiate between the volume depletion type of acute kidney injury and the volume overload type, because if you don't do this, you will miss your case. And these are the recent recommendation regarding the fluid use in this type. And I will not go in detail. This is the trend of using hemodialysis to get rid of the toxins, especially if you are using, for example, different materials of toxicity that I mentioned. There is a place for the hemodialysis and the hemoperfusion in the places in which we have facility for this. Again, there have been some trial of using alkaline phosphatase, but these failed. It did not give a good result. Albumin, as a part of the initial volume replacement, may have a role in low serum albumin patient only, and severe sepsis and septic shock when patient requires substantial amount of crystalloids. Of course, Dr. Hussein last time mentioned that balanced crystalloid are better than saline in critically ill patients, and we will get these better. Vasopressor, especially norepinephrine, glycemic control in central illness renal effect, getting a good energy intake and a good protein intake. Is there an optimal time to initiate the renal dialysis? Of course, if you do it too early, increased cost in the developing world, impact on the renal recovery not known, and loss of the residual volume. Too late, the patient will die. So let's go to the optimal, which is when we have indication. And this is a comparison between Akiki, Elaine, and ideal ICU trial, showing actually that it's better to go when no much difference, and it's better to go when you have clinical manifestation, not very good to go very early. And this is FIST trial, again, another recent trial telling when to start. These are different publications. For the sake of the time, I will go very rapidly through them, but I want to tell you that the timing of dialysis is still many studies, not only the Elaine and Akiki, the START AKI and the Akiki 2, all these are still questioning what time, when to dialyze, simply when the patient has symptoms or when it is neither early nor it is late. Is there any role for PD in developing world? Yes, in this publication, high volume peritoneal dialysis could be used whenever you don't have the facility to do something else. It will work and it will save your life, the life of your patient. Is there any difference between the CRRT versus the intermittent hemodialysis? No difference, as you see in these old publication, and no difference again in the current clinical practice. What you may use it well, use it. أو كما يقولون اللي تغلب بيه العب بيه. So the availability, the experience, and the patient hemodynamic status will dictate us which type to use. Maybe for some patients with brain edema or for other concern, you will go for CRRT better. Thank you very much. I finished, and I hope that you all stay safe in this COVID area. Thank you.
Thank you very much, Professor Hani, for this very nice tour within the acute kidney injury within developing countries. Really, it was very stimulative, and I enjoyed this presentation very much. And I think one of the most important messages you delivered is to be cautious about everything, about the community, the drugs, environment. And this is what we should do by offering good health for the kidneys for all, to take care of everything. And because we are in developing countries, we are in lack of resources. So it's better to focus on preventive strategies rather than going for treating in an expensive way. And we hope to have the question now. I'm waiting the question on the phenyl. Dr. Ibrahim Sayed, phenyl toxin is a significant cause of severe acute kidney injury in Kenya and Luxor. It is related to hair dye poisoning. Is there? So this is Dr. Ibrahim from Saudi Arabia asking about phenyl toxin. Dr. Ibrahim Said from Saudi Arabia asked about phenyl and the hair dye poisoning. Thank you very much, Dr. Ibrahim, for this note. We should be cautious in everything, even dyes, because we observed this in a few cases of patients, even in lupus nephritis. Some hair dyes aggravates lupus nephritis activities. So this is why we should be careful about anything we use, even if touch, skin, hair, mucosa, everything. So we should be cautious because we can take poisonous effect from these hair dyes. And it is the one of the most famous hair dyes toxicity is a black dye that may lead to multi-organ failure. So we should be careful about anything. And if, regarding one of the most important points mentioned by Professor Hani is herbal remedies. Sometimes the local herbal remedies, we expect that it is safe, and at the end of the day, you can find toxicities. I received a phone call from one of the Arabic countries asking me about the nephrotic syndrome and the mercurial poisoning. And after I asked a history of the drug, I found that the patient was accustomed to use herbal ointment. And by reviewing the composition of herbal ointment, it was mercury. So be careful about using any drugs or medicine, and we should be very cautious. Is there any research about the topic of phenyl related AKI? We can do search and send it to Dr. Ibrahim as soon as possible. So if you allow me, as a commentary for this very nice panoramic view about the causes of acute kidney injury in the African countries and developing countries, I think we should be cautious about the environment. Professor Hani mentioned many details about drugs, exposures, the environment. So it is a time to be cautious about preventive strategies. We have primary prevention, secondary prevention, and tertiary prevention for kidney disease in general. And if we concentrate on the dehydration, because dehydration is very important risk for acute kidney injury, especially if we are in a hot weather countries like the majority of African countries, we should be cautious about dehydration. Regarding the last point in the presentation about the timing of dialysis, I think we have now the Lancet paper, which is very interesting meta-analysis because it reviewed all articles within 10 years or 11 years from 2008 to 2019, and even they included individual patient characteristics. And the conclusion was there is no superiority and no added value for doing early dialysis, but to take it as a practical message, yes, we shouldn't be rushing in doing early dialysis, but we should put the patient in focus under microscopy. So postpone dialysis as you can and put the patient on the close follow-up to avoid very delayed dialysis. And the indications of dialysis are severe hyperkalemia, severe metabolic acidosis, bicarb less than 10, pulmonary edema, uremic encephalopathy. We have now Dr. Hani. Ahmed. Dr. Hani. You are welcome back, Dr. Hani.
Thank you.
I shared some discussion until
مفيش مشكلة التكنولوجي بوظ الكونكشن معلش.
So we have another question: efficacy of hemodialysis modalities in bile pigment nephropathy, as in severe obstructive jaundice. Is it dialysable?
هو الحقيقة يعني أنت بتحاول تعمل الكلاسيك دياليسيس، بس in general الحاجات اللي هي بتبقى زي الشاركول برفيوجن وكده بتبقى في الليفر ديزيز more effective, which are not available everywhere الحقيقة. usually we perform classic dialysis بس الافيكاسي بتاعه بيبقى اقل شوية.
يعني maybe in the if we have obstructive cholestasis and the patient is hemodynamic compromise, so in this scenario we may select the hemodiafiltration or slow continuous therapy.
hemodiafiltration لما بيكون السايز اوف ذا فلتر able ان هو يجت التوكسين او ليفر توكسينز بدرجه احسن.
تمام. Ahmed, is there any question? So at the end of this presentation, I want to say one statement. It was very nice presentation, a very nice tour in the etiology of acute kidney injury in developing countries, and I think to put in mind and I think one of the we may raise this point is to increase the awareness of the public regarding all these points in a preventive strategy, and I think we can take the lead from the Egyptian Society of Nephrology and from African Society of Nephrology, and Professor Hani is the maestro here and there. Thank you very much, Professor Hani, for your excellent presentation. Hoping to meet you again and again. Thank you and goodbye.
Thank you. Thank you very much.
Goodbye.